Greetings. Let us talk about another hemostatic device, this time over the scope clip. These are my acknowledgements, and today's learning objectives include the following. We will learn about the uses of over the scope or over the endoscope clips, and also how to handle a clip and how to set it up. Unlike through the scope clip, if you want to use over the scope clip, you have to remove the endoscope from the site of operation and then place the cap fitted clip over the end of the scope and then go back to the field to deploy the clip. So in other words, in the presence of an emergency, if you want to use over the scope clip, you have to come out of that field, set up the clip, and then go back into the operating field to deploy the clip. There are a number of different types of clips. So here is one. This is known as type A clip, and I want to focus on the teeth. And these teeth are blunted and rounded. And this type A clip is used for hemostasis. In contrast to this type A clip with blunted and rounded teeth, this is type T clip, and I want you to focus on the teeth. These have small spikes, and this type T clip or therapeutic clip is used for closing perforations. This clip can be used in different parts of the GI tract. In contrast to the type T clip with small spikes, in the GC clip you notice longer spikes, and this is only used in the stomach for closure of gastrostomy fistulas that do not close spontaneously. Most of the peg site wounds, when you remove the peg, they close spontaneously within a few hours. In some patients, they may remain open and leak the gastric contents. In that case, if you want to use a clip, it is better to use this GC clip with long spikes to have a good closure. So now let us talk about how do you set up the OTSC system, over the scope clip system, and what are the components that are packed in that package. So you have a cap with a clip and a thread. So you have the cap, and over the cap there's a clip, and that clip is attached to a thread, and when you pull that thread, the clip gets deployed. So you attach the cap at the end of the scope, and you pull the thread through the biopsy channel using the thread retriever, and you attach it to this hand wheel, and if you turn the hand wheel, it tugs on the thread and allows the clip to come out of the cap and get deployed onto the tissue. So let us figure out how do you set up the equipment now, the OTSC setup. You take the hand wheel and place it over the biopsy port and secure it tightly. Next, insert a thread retriever into the hand wheel and push the thread retriever through the biopsy channel until it comes out. And once it comes out, you attach the thread to the thread retriever and then pull the thread through the biopsy channel and wrap the thread around the hand wheel and when you do that and you rotate the hand wheel until it is secure. Make sure that the OTSC cap is all the way firmly secured till its end. There should be no free space between the end of the scope and the OTSC clip. It should be firmly pushed all the way to the back. And that is the most important thing when you attach an OTSC clip to the distal tip of the scope. And you want to see where the thread is aligned to the biopsy port. If it is not aligned well, and as you can see, the biopsy port is at 7 o'clock, the thread is coming at 1 o'clock, and this will obscure the view of the endoscopist. In that case, you want to rotate the OTSC cap to align the thread to the biopsy channel, and once the thread is aligned to the biopsy channel, it provides a very beautiful view for whatever purpose it's going to be used. So, we've learned about how to set up the system. Key things are: make sure the OTSC cap is all the way firmly attached to the tip, all the way to the back, and the thread is aligned to the biopsy channel. So here is a bleeder, and this can be managed through the scope clips. If it is a big bleeder, OTSC clip can be used, and you go on and suction the vessel, rotate the hand wheel, and deploy the clip. So although it looks simple, as an endoscopy assistant, you have to be careful about a few things. Once you attach the OTSC clip to the end of the scope, even if it is a diagnostic scope or diagnostic EGD scope, the end of the scope with this clip attached becomes much bigger, much more stiffer, and hence as you assist the endoscopist during the procedure as a technician or as an anesthetist, you should give the jaw thrust to keep the airway and the neck in a straight line so as to be able to get into the upper sphincter without difficulty. One trick when you are using this device, especially in the setting of a bleeder, when the patient is already intubated, it is a good idea to ask the anesthetist to paralyze the patient so that the muscle tone becomes much more lax and allows the introduction of the scope with the OTSC clip on without much difficulty. Inserting the OTSC fitted endoscope through the upper sphincter is one of the most challenging aspects of endoscopy. So, if you use a GC clip, that is the largest clip, and the size becomes much larger, it can go up to 14-15 millimeters diameter. So keep that thing in mind. So let us talk about, we learned about different types of clips. In addition to clips, the OTSC system has other devices. Although OTSC is used with suction and then deploying the clip, sometimes the suction does not pull the tissue or suck the tissue into the cap. In that case, you could use a couple of devices known as tissue grasper, which has spikes to embed into the tissue and pull the tissue into the cap, or a twin grasper to grasp both the edges of a defect and then pull those edges into the cap before deploying the clip. So let us look at how do we use an OTSC clip depending upon the indication. So here is a bleeder, and Most bleeders can be managed through the scope clip. If in case it becomes technically challenging and you want to use an OTSC clip, you could use a simple suction technique to deploy the clip, especially when there is no scarring around that site. When there is scarring, the suction may not be sufficient to pull the tissue into the cap for deploying the clip. In the absence of scarring, you go close to the defect, suction, get the tissue till it obliterates the view, and then deploy the clip. However, when there is scarring, as you can see here in this diagram, in that case, you could use a tissue grasper and push it out, open the tissue grasper. It has spikes. It will anchor into the tissue and pull the tissue grasper deep into the cap and then deploy the clip. It is important when you use any ancillary device, either a tissue grasper or a twin grasper, it is important to pull the tissue and the anchor or grasper deep into the cap and then only deploy the clip. If you have the grasper or the anchor outside the clip and then you deploy, that clip will be stuck onto the device and it will be a mess. So here is a wound, it's a perforation. The defect is too big to be sucked in. So in that case, you could use a twin grasper, and you need to learn how to operate the right blade and left blade. And mentally, you have to say to yourself, this is my right blade, I'm opening the right blade. This is my left blade, I'm opening the left blade. And you have to play with that before you give it to the endoscopist. And then when the grasper is outside in the lumen of the stomach or in the colon, try to again repeat left blade opening, right blade opening, left blade closing, right blade closing, to do the dry run, so that when the actual closure is attempted, you would do that without having any errors. So you go into the middle of the wound, open the right blade, close it, that anchors that right blade, and then open the left one, close it, and then pull deep in and then deploy the clip. It's important again to have the twin grasper deep inside the clip, deep inside the cap before the clip is deployed. On the other hand, if it is a small fistula which has a lot of scarring and it is too small for a twin grasper, you could try to use the tissue grasper with the sharp ends and then deploy the clip. So we have learned about the over-the-scope clip device. One of the things you have to keep in mind is if you want to use the device in the middle of a procedure, you have to take the scope out, load the device, and then go back in. If you're going back into the upper GI tract, it is important to manage the upper airway, especially the hypopharynx, and the upper esophageal sphincter should be in line, and maybe the neck should be adjusted so that the intubation is easy. If the patient is already intubated with endotracheal tube, it's a good idea to ask the anesthetist to paralyze the patient. Once you go in, when you're applying the device, suction is very important. You want to make sure that there is enough suction before the device is deployed. If you use any ancillary device, it is important to pull it back deep into the cap before the clip is deployed. One of the side effects noted with this clip device is people have accidentally closed the pylorus, people have accidentally closed the duodenum, people have accidentally suctioned ureters. So it's very important to keep this thing in mind. Whenever you have a doubt that you may trap something in that case, instead of doing suction, you could try either a grasper or an anchor and pull the tissue and then deep into the cap and then deploy the clip. I hope this is useful. Thank you.